Our first speaker, Subhadra Jalali ma'am. So ma'am needs no introduction. You all know her for her work, which is done in retinopathy of prematurity. She also has done plenty of work on inherited retinal dystrophies and electroretinogram. So over to you, ma'am. So she will be talking on electroretinogram. From where does the signal come from?
Thank you all of you for being here. I think that post lunch we all need some electric shocks to remain alert, and that's what we are here for. So, where do these signals come from? That's what we want to know. So, we want to speak about from where the signals are coming from in terms of the cells in retina and optic nerve, and then what are the artifacts and how we look out for them. So I think over the last 50 years, we have gone from a global, like just putting a flash of light and recording some signals from the retina, to very local, like the macula, the paramacula, to very cell-specific response. And now the electrophysiology visual system is such that we can test for the on-cell pathway, the off-cell, the S cones, the rods, the cones. So many cells, and we have various tests like the electroretinogram, which can be done in various ways, like flash, multifocal, chromatic, then electrooculogram, the visually evoked potentials, and so on and so forth. So we'll not be going through all the techniques, but through some of the common clinical techniques that we use. So the flash electroretinogram, where we put a flash of light and then record the responses by electrodes, it measures the changing in resting potential of the eye. So normally the eye has some electrical potentials because there are bicarbonates, chlorides, potassium, sodium out there. But when the light falls on the photoreceptors, then there's a change in this resting potential, and that is what we record from the electrodes. In general, it's a good information that whenever the retina deteriorates, the electrophysiology also deteriorates to a very large extent. So you can see here the light will fall on the retina. There will be photoisomerization, of the rhodopsin and the visual cycle. And the photoreceptors themselves will get hyperpolarized, and they will pass on these signals into the bipolar cells. Now this is not a passive process. The bipolar cells magnify this signal, and that's why you see very large B waves, although the A waves are small. And then it is passed on to the ganglion cells and to the optic nerve. However, one must remember that this science is still evolving. There are still a lot of pathways that we don't know about, and new pathways keep on being told. So there is not like a rod pathway and a cone pathway. There's a lot of interaction between the two, especially in the inner retina, and that is where the whole processing of the signal happens. So it's not just signal is passing one place to other. So these cells which are there in the retina, they are arranged either radially or they are in between. So we can see here the general classical teaching being that the rod and the outer segments and the cone outer segments, they give the A wave, that is the downward going wave on your electrophysiology. And then when it goes to the bipolar cells, where the signal is modified and advanced and augmented, it gives the B wave, which is the upgoing wave. So this is more simplistically put here. So whenever you are analyzing the electroretinogram, just remember this diagram, which is inside out. In the retina, the rays of light will pass through the whole of retina and go to the photoreceptor. The photoreceptors are the only cells in the eye which can respond to light. So whether it is any signal that you're seeing, you should know that the photoreceptors are there. If they are not there, then you cannot study the rest of the pathway. So whenever the response is normal, we are looking at a light adapted response, a dark adapted response, and then we are seeing whatever response we are seeing, it is coming from the rods and from the L and M cones, and not from the S cones, because the S cones are very small, which means that if we want to study the S cones, we cannot use this bright flash. So to study the S cones, which sometimes we need a different protocol where we are using short wavelength flashes on an orange background. So like that we can study different cells by changing the parameters of the light, changing the adaptation, and so the signals from different types of cells in the retina can be amplified and seen. For example, here you can see that in a normal retina, this is how the waveform will come, but in a retina which has mostly S cones and it doesn't have L and M cones and doesn't have a lot of rod cells and bipolar cells related to rods, then the waveform will change, but still you can get a good reproducible waveform. So a normal flash ERG, when we record it in the dark adapted state, which gives us the dark adapted rod responses. Now these responses are not always directly from the rods, because the rod response will come as an A wave, but here you see there is no A wave. But what you see is a rod driven B wave, okay, and it is amplified. That is how you will see in normal. Whereas when you put very bright light, so this is a dim light, when you put very bright light, then both the photoreceptors, that is the A wave, and the bipolar cells connected to that, both the on bipolar cells and the off bipolar cells, will give the upward going wave, which is from the inner retina. So easy to remember is that the downgoing waves are coming from the outer retina, whereas the upgoing wave is coming from the inner retina. And obviously the inner retina cannot have the waves if the outer retina doesn't function. Okay, and so if the A wave is absent, then you know that the photoreceptors are not functioning. But if the B wave is absent, then you don't know, is it because the A wave is, the photoreceptors are dead, or both the photoreceptors and the bipolar cells are dead. So you can see here, sometimes these patients, they look like RP, but this is not RP. This is enhanced Escon syndrome. It's very different from RP. It has a very, less progression, and they have very typical findings. But the ERG can tell us that this is not RP, because in RP you'll get a flat, both rods and cones, because they're coming from there. But in enhanced Escon syndrome, if you do the Escon protocol, then you can see that the signals are coming from the Escon. Now, so that was about the flash ERG. The pattern ERG here, the responses are, we are taking the responses from the macular area, because the flash ERG cannot tell you anything about the visual function or the visual acuity of that patient. It only tells you about the health of retina. So you can have an absent flash ERG, but still the patient can see 6/6. That is because the flash ERG is testing the whole of the retina, and the macula is a very tiny part of that whole retina. So when we want to look at the macular function or correlate to the visual acuity, we look at the macular photoreceptors by either pattern ERG or by the multifocal ERG. And these waveforms, they come from the photoreceptors. So here you can see the first waves, which is the P50. This is coming from the macular cone cells, whereas the N95, which is the lower part, it is coming from the ganglion cells. So there's a different origin of these two waveforms, and so these two cell types can be studied by the pattern ERG. Whereas from the multifocal ERG, here the macula has only the cone cells predominantly, so it is coming from the on and off bipolar cells, most of the signals, which are generated by the macular cones. So those who will speak on these topics will tell more details. I'm just telling from where these signals are coming from. So you can see here that these signals, while they come from these cone cells, they are also influenced by what light is put before or after, because as you know, if you put light on the retina, it gets light adapted, and then it cannot respond immediately. It has to go to a dark adapted state to come back and give that signal. So if you put multiple flashes very fast, then obviously there will be a different response than if you put a dark and then a light and then a light and then a dark. So that is how this system works to give us the ultimate outcome of whether it was a light, dark, dark, or a dark, light, light, like that. Once we come to the EOG, now EOG, some people have this misconception that this is a signal from the retinal pigment epithelium, because this is what we use for Best disease, which is an RP disease. But here what we are doing is, although we are studying the change in potential of the retinal pigment epithelium, the cells don't respond to light. As I said, the cells, only the photoreceptors respond to light. So once the photoreceptors respond to light, there is a change in the electrical area or the chemical composition between the retinal photoreceptors and the pigment epithelium, and the pigment epithelium potential rises. Now if you see carefully, the potential is very big because it is in millivolts. What I was showing before was in microvolts. So the ERGs are VPs, ERGs, multifocal ERGs, they are all in microvolts, whereas the EOG is in millivolts. So once you put light on the eye, the potential of this RP changes and it rises, and that is what we call as light rise. So I will just like to say that the VP signals, again, they are not generated by the optic nerve. They are only passing from the optic nerve, and we get the response from the occipital cortex. But for VP to generate, the photoreceptors should be healthy. So if we don't know from where the signals are coming, or whether the patient is not seeing from macular disease or optic nerve disease, we must do ERG and VP, not just VP, because VP can be absent in large macular disease also. So there are a lot of variations which can happen, which could be physiological, technical, or pathological. So before we interpret an ERG, we should keep all these factors in mind, which can influence what the waveform is. But one thing is sure, when there is a disease, the waveforms change drastically. It's not like 300 will become 290. The 300 will become 50 or 100. So that is the beauty of ERG, that the change is huge when there is a disease. So it is not difficult to pick up. Thank you.
So thank you so much, ma'am. So any questions from the audience or any comments? Basics? Fine. Fine. So if there are no questions, I'll just start my talk. I'll be talking on fulfilled ERG, when to order and what to look for.